Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper. We had a string of hyponatremia cases during my night shifts this week that got the team talking. We debated whether we should be pushing for intensive correction or if our standard care is actually sufficient. I brought the HIT trial to rounds to settle the debate, and I wanted to share those insights with you.
Welcome to Prism Rounds, where we discuss trials, guidelines, and evidence shaping pulmonary, critical care, and sleep medicine. This deep dive uses AI-generated voices for educational discussion and should not replace clinical judgment.
Right. Definitely an important disclaimer before we get into it.
Yeah, absolutely. So picture this. It is 2 a.m. on the night shift. You are sitting at the workstation, the glow of the EMR is just burning into your retinas, and suddenly your pager goes off.
Let me guess. Another sodium alert.
Exactly. It's always a sodium alert. Now, they say salt is the salt of the earth, but in the ICU at this hour, it is usually just a massive headache.
It really is. I mean, it is that classic clinical dilemma that just haunts the wards.
Oh, for sure.
You see that low number in red on the screen, and you have to ask yourself whether you're actually treating the patient or just, treating the laboratory monitor.
Okay, let's unpack this, because when we aggressively try to fix moderate hyponatremia, are we actually improving outcomes? Or are we just making the numbers look pretty for morning rounds?
That is the million-dollar question.
Right. So to figure this out, we're pulling from a really solid stack of sources today. First, we have the foundational 2022 JAMA review by Adruge and colleagues.
Which is excellent for the pathophysiology and management side of things.
Definitely. We also have the highly anticipated 2026 HIT trial, that's the Hyponatremia Intervention Trial, published in NEJM Evidence.
Yeah, that one really shook things up.
It did. And finally, just to contextualize all of this, we are looking at the accompanying editorial by Kumachev and Macmillan.
So, grounding ourselves in the JAMA data first, it is worth remembering why this particular electrolyte imbalance generates so many pages.
Yeah, why is it always sodium?
Honestly, it comes down to sheer volume and the clinical stakes. Hyponatremia, which is officially defined as a serum sodium level of less than 135 millimoles per liter, is the single most common electrolyte disorder we encounter.
Which is wild to think about.
It really is. It affects about 5% of the general adult population, but a staggering 35% of hospitalized patients.
Wait, 35%? That is more than 1 in 3 patients.
Yep.
Well, that definitely explains the endless alarms. But, the pushback I often hear from newer clinicians is, well, if it is that ubiquitous, maybe it's just a normal physiological response to acute illness.
Right, like an adaptive thing.
Exactly. Why should we care so much if a patient's sodium is just sitting at, 131?
Well, the stakes are actually very real, even at those mild levels. Chronic mild hyponatremia is definitively linked to subtle but really dangerous neurological shifts.
Dangerous in what way?
The JAMA review highlights prospective data showing that these patients have significantly higher rates of cognitive impairment and gait disturbances.
Oh, wow. So it's physically affecting how they move.
Exactly. In one study, nearly 24% of patients with chronic hyponatremia reported a history of falls, compared to just 16% of normonatremic patients.
That is a huge jump.
It is. And over a 7-year follow-up, they exhibited a much higher rate of incident bone fractures. It acts almost like a secondary cause of osteoporosis.
Wait, really? Osteoporosis?
Yeah. Furthermore, it is independently associated with increased length of hospital stay and higher overall mortality.
Okay, so the correlation with bad outcomes is undeniably there. But to fix it, I feel like we have to look at the underlying physiological math, right?
Definitely. How do you usually explain it to residents?
I like to frame the Edelman equation kind of like mixing a pitcher of lemonade.
Oh, I love a good food analogy.
Right. So if you pour a glass and it tastes incredibly weak and watery, which is essentially what hyponatremia is, it is rarely because you failed to put enough lemonade powder in the pitcher.
Right, it's not a lack of salt.
Exactly. It is almost always because you added way too much water. So in the body, the powder is the total exchangeable sodium and potassium, and the water is total body water.
That is honestly the perfect way to visualize it. Hyponatremia is fundamentally a disorder of water homeostasis.
So it's a water problem, not a salt problem.
Exactly. It is an excess of water relative to the body's solutes. A healthy kidney is actually incredibly efficient at excreting excess free water.
Yeah, they can dump what, like up to a liter an hour if needed.
Yes, easily.
Huh.
But in our hospitalized population, something is derailing that water diuresis. Vasopressin is usually the culprit here.
Ah, vasopressin.
Right. It actively prevents the kidneys from letting the water go. Recognizing that we are dealing with a water problem rather than a salt deficiency problem kind of dictates our entire therapeutic approach.
Okay, so if hyponatremia is just a too much water problem, it feels like the solution should be as simple as, I don't know, wringing the patient out like a sponge.
That is the logical leap, yeah.
Is that what the HIT trial finally tried to do? Because we have established that low sodium is linked to falls, fractures, and longer stays. So the clinical logic suggests that aggressively driving the sodium back to normal must benefit the patient.
Well, that was the exact premise of the 2026 HIT trial. It was a massive, pragmatic, randomized controlled trial conducted across 9 different European centers.
Okay, for those of us who haven't drafted a research paper recently, walk us through the PICO. Who was the specific population and what exactly was the intervention here?
So the population included 2,173 adult patients.
Wow, over 2,000. That's a great sample size.
It really is. The median age was 73 years old, which captures, the typical demographic you were admitting at 2 a.m.
Oh, absolutely.
And these patients all had chronic hypotonic hyponatremia with a median baseline sodium level of 127 millimoles per liter.
Okay, so we are looking specifically at moderate chronic cases here.
Exactly.
A huge, well-designed study targeting older folks with a sodium of 127. So what did the intervention group actually get?
They received what the study called targeted correction. This was a multifaceted, etiology-based algorithm with daily escalations driven by the trial team.
Daily escalations, that sounds intense.
It was. They started by trying to wring out the sponge with severe fluid restriction.
Which patients absolutely hate.
They despise it. And if restricting oral intake didn't work to raise the sodium, the algorithm escalated to oral urea.
Ugh, I always cringe when I see oral urea ordered.
It is pretty rough.
It is. Making a patient drink the very waste product their kidneys normally filter out seems brutal. The palatability is just notoriously awful.
Yeah, it tastes terrible. It often requires patients to mix it in sweet syrups just to get it down.
Just to mask the taste.
Right. But physiologically, it is highly effective.
Yeah.
Giving oral urea increases the solute load in the renal tubules.
Because it acts as an osmotic agent, right?
Exactly. Because urea is an osmotically active particle, it obligates water to follow it out into the urine.
Ah, so it forces an osmotic diuresis.
Yes, and it does it without depleting other crucial electrolytes.
Okay, fair enough. But what if the urea failed to wring out enough water? They couldn't just keep giving syrup, right?
No. If that failed, they brought out the heavy artillery. They escalated to Vaptans.
Ah, the expensive stuff.
Very expensive. These are drugs that directly block the vasopressin V2 receptors in the kidneys. It is basically the nuclear option for aquaresis.
Because it actively prevents water reabsorption right at the collecting duct?
Exactly. The absolute goal for this targeted group was to relentlessly push the sodium into the normal range of 135 to 145 millimoles per liter.
Relentless is definitely the right word. Let me guess. The control group just got the classic watch and wait treatment.
Yep. They received standard care. The hyponatremia was managed entirely at the discretion of the attending physician without any strict trial-mandated targets.
Okay, so they threw the kitchen sink at the intervention group, severe fluid restriction, terrible tasting urea, and expensive Vaptans. Please tell me it actually worked, and we haven't been torturing patients with oral urea for nothing.
Well, if you were looking solely at the laboratory monitor, the intervention was a resounding success.
Okay, that's something.
Yeah, in the targeted group, 60.4% of the patients successfully reached normal sodium levels. That is compared to only 46.2% in the standard care group.
That's a pretty solid jump.
It is. Furthermore, the maximum absolute change in sodium was higher in the targeted group. It was 10.0 versus 8.7 millimoles per liter.
So the targeted correction undeniably made the labs look prettier.
It absolutely did.
Okay, but I sense a massive however looming over this data.
A definitive one. What's fascinating here is that the primary outcome wasn't a lab value at all.
Right, because we care about the patient, not the blood draw.
Exactly. The primary outcome was a composite of death or rehospitalization within 30 days. And despite the significantly prettier lab numbers, there was absolutely no difference in patient-centered outcomes.
Wait, none at all?
None. Death or rehospitalization occurred in 20.5% of the targeted intervention group versus 21.8% of the standard care group.
Wow, that is incredible close.
The p-value was a highly non-significant 0.45.
Okay, so a total wash.
Totally. The 95% confidence interval crossed zero completely, ranging from -4.9 to positive 2.2.
Did they look at anything else, like quality of life stuff?
They did. They examined secondary outcomes like length of hospital stay, intensive neuropsychological testing, and falls at 30 days.
And
There's no difference across the board.
I have to push back here. Wait, if the intervention hit the lab target perfectly, but the patients didn't actually feel the benefit of staying out of the hospital, does that mean we've just been treating the monitor?
It really forces us to examine the underlying mechanisms of why the intervention failed to move the needle.
Because if someone is falling down and experiencing cognitive impairment from a sodium of 127, it feels clinically counterintuitive to just leave it there. Are we looking at a flaw in the study design or a flaw in our understanding of the disease?
One major consideration brought up is the time frame. A 30-day window might simply be too short to see a reversal of chronic issues.
That makes sense.
Right. If a patient has sustained subtle bone density loss or long-term gait alterations from chronic hyponatremia, correcting their sodium for a few days in the hospital isn't going to miraculously rebuild their bone trabeculae.
Right, or rewire their muscle memory by day 30. Reversing osteoporosis takes years, not weeks.
Exactly.
I also wonder if the side effects of the targeted treatments ended up, canceling out the theoretical benefits.
How do you mean?
Well, severe fluid restriction makes patients miserable and thirsty. Oral urea causes nausea. If you are making a 73-year-old patient nauseous and dehydrated, they probably aren't getting out of bed to work with physical therapy.
Which completely negates any potential improvement in their gait or fall risk.
Exactly. They just stay in bed feeling awful.
That is a highly plausible mechanism. The secondary endpoints in the HIT trial actually included things like the timed up and go test and the Montreal Cognitive Assessment.
And no improvement there either.
Neither showed significant improvement in the targeted group at 30 days. The burden of the treatment may have just offset the biochemical win.
Which flows naturally into the NEJM Evidence editorial by Kumachev and Macmillan. They directly debate whether this targeted treatment is actually helpful or if it is just unnecessary clinical busywork.
Yeah, and reading their take gave me serious déjà vu.
Oh, regarding how we used to manage critical care patients.
Yes, we have certainly seen this cycle in ICU history before. The editorial draws a really vital comparison to intensive blood glucose management.
Oh, the nice sugar trial era.
Exactly. Decades ago, we observed that hyperglycemia was associated with poor outcomes in critically ill patients.
So the logical leap was that aggressively normalizing blood glucose with intensive insulin therapy must be beneficial.
Right, but large-scale trials eventually proved that intensive control actually caused severe episodes of hypoglycemia.
And ultimately increased mortality. We learned a very similar painful lesson with intensive blood pressure control in the acute setting, too.
Oh, absolutely. Pushing too hard to achieve a perfect normotensive state often just leads to iatrogenic hypotension.
Right, and organ hypoperfusion without any long-term survival benefit.
It is the hubris of thinking we can micromanage complex systemic compensatory mechanisms with a single variable.
Man, that's well said.
The editorial makes a compelling argument that for moderate hyponatremia in hospitalized patients, our current laid-back standard of care might just be good enough.
Good enough. I like that. Expending all this extra effort, escalating to urea and vaptins just to force the plasma sodium into a normal range, simply isn't benefiting our patients in the short term.
No, it's really not. The editorial emphasizes that instead of hammering the sodium number, the true standard of care is treating the underlying cause.
So going after the root of the water retention.
Exactly. If the hyponatremia is a reflection of too much water, we have to ask why the body's holding on to that water in the first place.
Usually it is driven by a reduced effective arterial blood volume, right?
Yes. Think about your patients with severe heart failure or advanced cirrhosis. The cardiac pump is failing, or the splanchnic vessels are massively dilated.
So the kidneys sense a lack of perfusion and think the body is dangerously dehydrated.
Even when the patient is visibly third spacing and completely overloaded with fluid.
Right. So the body responds to that perceived dehydration by releasing vasopressin to desperately hold on to water.
Exactly. Alternatively, you have SIADH, the syndrome of inappropriate antidiuresis, where the body is releasing vasopressin entirely inappropriately.
Right, due to a pulmonary tumor, a central nervous system issue, or a medication side effect.
Exactly. So if you optimize the heart failure exacerbation with proper diuresis and afterload reduction,
Or manage the cirrhosis.
or find the offending medication causing the SIADH, the physiological trigger for the vasopressin release disappears.
And the body will naturally let go of the water, and the sodium will correct itself.
Once you fix the engine, the check engine light turns off on its own.
That's a great analogy. But wait, what does this all mean for the patients who are truly unstable?
Ah, yes.
Because if we just preach this good enough philosophy across the board, someone is going to ignore a critically low sodium and cause a complete disaster. We definitely need to outline the safety nuance here.
We do. The JAMA guidelines are incredibly explicit about the exceptions to this relaxed rule.
Okay, so who are the exceptions?
First, we have to look at severe symptoms. If your patient is experiencing seizures, a coma, or severe cardiorespiratory distress, you are dealing with a medical emergency.
Right, you do not wait around trying to optimize their heart failure meds.
Absolutely not. That patient is experiencing severe cerebral edema.
The brain is actively swelling against the skull.
Yes. At that point, you need immediate bolus therapy with 3% hypertonic saline to acutely raise the serum sodium, pull water out of the brain tissue, and reduce the intracranial pressure.
Okay, so severe symptoms get hypertonic saline. What's the second exception?
The second major exception is extreme hyponatremia. Remember, the HIT study specifically focused on moderate cases. The median sodium was 127 millimoles per liter.
Right.
Only 6% of the patients in that entire massive trial had a sodium level below 120 millimoles per liter.
So if your patient is admitted with a sodium sitting at like 114, the HIT trial data does not grant you a pass to just watch and wait?
Definitely not.
Sure.
Extreme hyponatremia requires vigilant, highly monitored management in the ICU.
And the reason extreme chronic hyponatremia demands such intense respect is because of the most terrifying acronym in nephrology, right? ODS, osmotic demyelination syndrome.
Ugh, it is the ultimate nightmare scenario.
It really is.
When a patient has chronic hyponatremia, their brain cells do not just passively swell. Over the course of about 48 hours, they actually adapt to the low-sodium hypotonic environment.
Okay, for those of us who haven't looked at cellular biology in a minute, give us the mechanism. How do the brain cells survive the dilution without bursting?
So the brain cells shed organic osmolytes.
Organic osmolytes.
Yeah, you can think of organic osmolytes as the brain cell's internal sandbags molecules like taurine, glutamine, and myoinositol.
Okay.
When the surrounding blood gets diluted, the brain cells dump these osmolytes into the extracellular space. This lowers their internal osmotic pressure so they don't draw in excess water and swell. The brain basically recalibrates to survive in a diluted soup.
So the brain becomes perfectly stable, existing at a sodium of 115. But if we rapidly correct the sodium, pouring in a concentrated solution to hit a normal number quickly,
We plunge those adapted, osmolyte-depleted brain cells into what is now, relatively speaking, a severely hypertonic environment.
which reverses the process entirely.
Exactly. The rapid osmotic stress pulls water out of the brain cells. They severely dehydrate and shrink.
Oh, wow.
This rapid shrinkage causes massive astrocyte injury and triggers apoptosis in the oligodendrocytes.
And those are the cells responsible for maintaining myelin.
Yes, so it strips the myelin sheath right off the nerves, particularly in the central pons of the brain. And that demyelination causes permanent catastrophic neurological damage.
Devastating damage. We are talking about quadriparesis, severe Parkinsonism.
And locked-in syndrome.
Right, where the patient is fully awake and cognitively intact but cannot move a single muscle except their eyes.
It is entirely iatrogenic, and it is frequently fatal.
Man. So, did the HIT trial's aggressive targeted protocol cause any cases of ODS?
Fortunately, there were 0 cases of osmotic demyelination syndrome in the trial.
Well, that's a relief.
However, the overcorrection rate, meaning the sodium rose faster than the safety limits allow, was 2.3% in the targeted intervention group
Versus what in the control?
versus 1.4% in the standard care group.
I mean, that is a small percentage difference, but when the potential consequence is locked-in syndrome, knowing you doubled the risk of overcorrection is enough to make your stomach drop.
That is precisely why the guidelines are so rigid. For chronic hyponatremia, you must avoid correcting the sodium faster than 8 to 12 millimoles per liter in a 24-hour period.
Because you have to give the brain time to synthesize and reaccumulate those organic osmolytes?
Exactly. It is a delicate tightrope walk. You want to improve the physiological state, but if you push too hard too fast, you risk destroying the patient's brain.
Okay, synthesizing everything from the JAMA deep dive on cellular pathophysiology to the pragmatic realism of the HIT trial and the cautionary wisdom of the editorial. Let's distill this into our PRISM pearls.
Sounds good.
What are the concrete takeaways clinicians should carry into their shift tonight?
Pearl number 1. For hospitalized patients with moderate chronic hyponatremia, our current standard approach is likely good enough.
Right.
The HIT trial proved that intensive targeted correction using algorithms and specific medications normalizes the lab values more effectively, but it simply does not improve 30-day mortality or rehospitalization rates over routine care.
Pearl number 2, focus your clinical energy on the cause. Instead of ordering terrible-tasting urea or reaching for expensive Vaptins just to make the lab value turn green on the monitor, put that effort into optimizing their heart failure.
Or managing their cirrhosis or finding the root cause of their SIADH.
Exactly. Treat the patient, not the monitor. And what's our third pearl?
Pearl number 3, keep an eye on the age factor.
Oh, right, the subgroup analysis.
Yeah, while the overall trial did not show a difference, the authors did note a possible signal for benefit from targeted treatment, specifically in older adults, patients 70 years or older.
So we shouldn't totally write off targeted correction just yet?
Right. It wasn't the primary endpoint, so we cannot rewrite protocols based on it today, but it suggests we really need to look closer at how age interacts with sodium correction and fall risk in future studies.
So what does this all mean at the end of the day? We brought up the check engine light analogy earlier, the idea that you can put a piece of black tape over the light on your dashboard by forcing the lab value to 135 without actually fixing the car.
The dashboard looks normal, but the engine is still failing.
Right.
Which really makes you wonder if we eventually get to a point where AI or advanced biomarkers can instantly diagnose that underlying engine problem the moment a patient hits the ER doors.
Yeah.
Will we even need to check routine sodium levels at all?
Oh, that's an interesting thought.
If the sodium is just a lagging indicator of a problem we can already pinpoint and track, will this entire agonizing 2 a.m. ritual of fluid restriction and monitoring become completely obsolete?
Now, that is definitely something to ponder while you chart tonight.
Keep an eye on the future.
Always. Thanks for joining us on PRISM Rounds. Until next time, stay curious, stay critical, and take good care of your patients.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.